There we go, 55. So, do you think we should start?
No.
9:03? Okay. So, thank you. Welcome, everybody. Can everybody hear me okay? Come across? Okay. Welcome, everybody, to the UBC Academic Department of Emergency Medicine Grand Rounds for December, the last month of 2020. We'll have this year behind us pretty soon. And we're very grateful to have Dr. Kendall Ho to be hosting this, and he'll introduce our guest speakers, talking about where we are now with COVID-19. I know a topic dear to all of your hearts. I would just like to us all right now, as the very first item of business, to think about where we work, live, and pray, maybe. That we're on the lands of the ancestral peoples of North America in different places. In my case, where I live, I am very privileged to be on the lands of the Coast Salish peoples, which includes the Musqueam, Squamish, and Tsleil-Waututh nations. And so if we'd each take just a moment to think about where you are and the history of where you are and the keepers of the land long before white settlers came to North America. Thank you. And now I will hand the proceedings over to Dr. Kendall Ho. Thank you, Kendall, for doing this.
Great. Thank you very much, Jim. First of all, really thank you, everyone, for being at this morning's round. We have three really high-power and very knowledgeable individuals updating us on COVID, which we all pay attention to. So it's great to have this timely update. I also want to right away acknowledge Dr. Reka Gustafson. He is really the brain behind today's round. I'm a guest facilitator because he unfortunately got called into, paradoxically, some really important COVID meeting. And so, unfortunately, he can't be here, otherwise he will be chairing. And so it's my privilege to be here to facilitate this meeting. We have three speakers. I'd like to introduce Dr. Dave Sweet first. In fact, many of you know him, well, all of you know him well. In fact, he is not only clinical associate professor at critical care and emergency medicine, also chair the COVID Therapeutics Committee. And so we're going to have him speak first. He's actually on shift or on ICU right now, so thank you so much for sparing the time. Dave may not be able to stay with us throughout this event, so we'll have him speak first, and then I'll introduce Reka and Marc as we move forward. So Dave, I want to hand the time over to you. Thank you so much for spending time with us.
Great, my pleasure. Can you guys see my slides now? Excellent. So first, I want to say that it's important to know that I am just the voice of an incredible group of people that have been dedicated and working on this project since March. A little bit background. So we met the first time on March 13th as a coastal initiative, and then eventually branched out to the entire province to make the BC COVID Therapeutics Committee. This group now has expanded to over 50 individuals, including MDs, pharmacists, researchers, administrators, policymakers, and we represent all the health authorities and the Ministry of Health. Many different backgrounds in our group, from critical care, infectious disease, medical microbiology, all the way over to hematology, rheumatology, anesthesia, long-term care, transplant medicine, you name it, and ethics. Our group usually meets on Fridays, and we bring up new information that we found and discuss it and have votes occasionally to change recommendations.
Right away, they don't have to wait like 40 minutes or whatever it's actually.
Excuse me, whoever whoever is just listening, please put on mute. And Dave, thank you. Sorry for the disruption.
So individual members take on a different drug, and they present weekly on that drug to the group. We have 3 online documents, an infographics, which I'll share with you, and then a 100-page document that summarizes all the research, and a 1-page recommendation sheet if you're interested. And these are all available on the CDC website. So this is not a complete list of all their members, but I do want to highlight some emergency members that have done incredible work with us. First off, Andrew Guy was a resident who has been helped Adam with the initial literature searches when COVID first hit. David Muleman, I cannot say enough good things about this guy. Like, obviously knew him as a resident, and I've been truly impressed with his advancements in the world of ethics, and he really contributed a lot to our group around ethical decision making. Rob Stenstrom, anything infectious disease, of course. He's been involved and helped analyze the literature. And finally, Adam Thomas. He has been a huge asset to the critical care world in the province in sort of summarizing literature and knowledge translation. So this is our infographic. I know you can't see the details of it, but if you want to go to one-stop shop to get all the information you need, this is probably it. The big green boxes are the only things you really need to know, because that's where the evidence is and the recommendations that we've made. I'm first going to go down here and talk about antiviral therapy, specifically in the group of patients that are just on oxygen. So Remdesivir, the only one we're going to talk about. It's been the bane of my existence for the last month or two. The issue with Remdesivir is twofold, to give you an update. So two different studies you need to know. The American Act 1 study, which is a 1,000-patient randomized blinded controlled trial powered to look at reduction in time to clinical. This found around 5 days, okay? Not powered to look at mortality. Then we have the Solidarity trial, which is the WHO trial, 5,000 patient, open label design, powered to look at mortality, but not really well designed to look at time to clinical recovery or hospital stay. They found no difference in anything. They found no difference in mortality, no difference in time to deterioration, or if you deteriorate, you require mechanical ventilation. They found no difference, actually, well, they didn't find a reduction in time to discharge from hospital, but in fact, in all the arms that got drugs within their study, compared to placebo, those patients were less likely to be going home at day 7 if they were getting any drug. And that's obviously because it was open label, and that the clinicians or the patients wanted to be kept in hospital probably to finish their course of 10 to 14 days of drug to see if there's a mortality benefit or give them that benefit. So we had trouble reconciling these two different studies. At first, we had very little Remdesivir coming into the province, so we allocated it just to randomized controlled trials, the CATCO Solidarity trial. But as time went on, more and more drug came to the province, the numbers were increasing throughout the province, and there may be this signal to reduce time to clinical recovery from Act 1. And so we worried that we needed to release it from the trials, because it may reduce the time to recovery and therefore take a burden off the healthcare system. Since then, and then finally, there's only Coastal was enrolling patients in CATCO and not Fraser, Interior, et cetera, where a lot of the numbers were really going up. So after that, WHO made a recommendation against Remdesivir in any patient population. That's thought to be because they have a global lens and low-income countries and the cost of the drug. So with that recommendation, we've seen less use of Remdesivir in the province. A reanalysis by the WHO as well as some of the data from Act 1, maybe that 5-day time to clinical improvement is actually less, depending how you look at the data. So where we're at now is you can use Remdesivir only in patients on oxygen, but not mechanically ventilated. But realistically, you should have a discussion with your patients, potentially if they're the one prescribing, about their preferences and values, and make a decision if you'd like to treat Remdesivir. My gut feeling, I think it probably does very little, and it's not worth the money that it costs, $3,000 per treatment. Moving on, I talk about immunomodular therapy. So this includes the critically ill patients that are mechanically ventilated and the patients that are just on oxygen. I'm going to blow up the boxes so you can see them. Most important thing to understand, steroids do work in this disease. I think it is now widely accepted. Specifically, the recovery trial that was the dexamethasone, 6 milligrams a day, found that there was a reduction in mortality of around 30% for mechanically ventilated patients and 20% for patients that are on oxygen. And the WHO meta-analysis of all the studies that were being done and stopped showed an odds ratio of 0.66 for mortality. So definitely need steroids if you're on oxygen in the hospital or critically unwell. What about all the other biologics and small molecules you see there? You may have heard of some of these in the literature and the media. Tocilizumab was watched very closely in the beginning, thought to be potentially beneficial. All the studies, though, the randomized trials that were coming up came up negative, suggesting that tocilizumab did not have the benefit we thought. Then about 2 weeks ago, there was a tweet by the REMAP CAP group, Derek Angus's group out of the U.S. that have, I think, 80 study centers over the world, and they have been stopped by their DSMB because of the efficacy. So suggesting that tocilizumab in their patient populations in practice improves outcome, an odds ratio of 1.87, with a high degree of certainty, 99.7%. All we know is that these patients, if you look at trials.gov, had to be in the ICU within 48 hours of arrival and then mechanically ventilated within 48 hours of coming to the ICU. We haven't seen the hard data, but watch tocilizumab. I think it will be recommended treatment in the future is my guess. Passive immunotherapies, Regeneron in the US, you've heard of that. I'm sure you've heard of Remdesivir, Canadian-based country. Accelera worked with Eli Lilly. So this drug has gotten an emergency use approval within Canada from Health Canada, and it has been purchased in a large amount. What's concerning to us is this was based on the BLAZE-1 study, which is an interim analysis of a phase 2 trial. This is for patients that were not hospitalized, and in fact, they never even hit their primary outcome of reduction in viral load between all their doses at day 11. Now, of the 3 doses they gave a small dose, a large dose, and a medium dose. The medium dose is the one that hit statistical significance at 11 days. Not sure what to take out from that. And there's secondary endpoints that looked at hospitalizations and emergency department visits and death, of which there was no deaths. There was a small difference in the visits and the hospitalizations in the BAMLAM group. But again, not sure how clinically relevant that is. Now, important with BAMLAM, what we're concerned about is that there is a whole bunch of this coming to the province. This is for patients that are outpatients. All the inpatient studies have been stopped, so outpatients with a risk factor. It's an IV infusion. It needs to be given over an hour and then a 2-hour observation period. And then in addition to that, out of the 300 patients they looked at, 2 had anaphylaxis or anaphylactoid reactions. So how could this ever be operationalized within the province at this point in time? And for this group, there has been some comments that maybe emergency rooms would be where these highly infectious people would come in to get their infusions before going home. So we feel there's not good evidence for that, and right now we're just negotiating how to deal with this subject. Last thing I just want to mention from Therapeutics as well, so enoxaparin, so we do suggest higher DVT prophylaxis in the intermediate groups, enox 30 BID, sorry. I think you know that because there has been reports of higher DVT and TEs, more reports coming out on bleeding, many randomized trials going on looking at full anticoagulation versus intermediate dose or low dose prophylaxis. So we'll have to keep our eye out for those and change our algorithms as we go forward. Did we do a good job? I don't believe I spoke about this at our last time I presented here, but this is a study from CMAJ by Anish and Don Grisdale. They looked at 6 ICUs in Vancouver, over 117 COVID patients, and we're proud that from our therapeutic standpoint, that only 4 patients got tocilizumab and 1 patient got hydroxychloroquine. So we feel our guidance was successful and that inappropriate therapies were not given to patients in BC. And with that, we have one of the lowest mortalities in the first world of around 15%. That's all I wanted to give as far as an update. I can take some questions. I might answer one just quickly that I keep getting is around either vitamin D or Provincial. There's been some work done on those studies that are interesting, mostly observational work, nothing that would be practice changing. So maybe I'll stop there so everyone else the other speakers can have a shot, and I'll answer a question or two if people have.
Excellent. Dave, thank you so much for excellent update. If you can stop sharing the screen so that we can all see everybody. Please feel free to use the chat room, or if you want to put up your hand, I'll scroll through the screen. And also on your participant, you can also put up your hands there. So I'll look at all 3. So please use chat or put up your hand physically or put up your hand electronically. I know Dave will be only joining us for maybe another 5 minutes or so, so we'll open up for some questions for him, and then we'll move on to our other speakers, and we'll go from there. Any questions? There's one. How about ivermectin for prophylaxis, Dave?
Yeah, ivermectin, some interesting work that's been done on that. We do not recommend ivermectin for prophylaxis. In fact, there's nothing that we recommend for prophylaxis. The interesting one with ivermectin is the idea that some patient populations are higher risk of strongyloides and will get hyperinfectious syndrome if you get steroids. So in certain patient populations, certain people around the world are giving ivermectin with their steroids just in case. And I believe there was a case at St. Paul's that they did know that they had a history of strongyloides in the past. So ivermectin would be the use, that's where we recommend its use, but not as prophylaxis, no.
Thank you, Dave. Other questions? Let me see. I think there may be another one. Nope.
there aren't any, you can write me and email me anytime. I'm more than happy to answer questions one-on-one too.
Excellent.
Representatives that you saw from Emergency that's been working with us. It's been great.
Excellent. Any other questions?
All the information can be found on the CDC website. Thanks, guys.
Excellent. Dave, thank you so much. I really appreciate your time here. And please, of course, you're on clinic, so please feel free to leave or stay as long as you want. But really very enriching information. Thank you, Dave. So why don't we move on to our next speaker. We have Dr. Reka Gustafson joining us. Reka is a clinical associate professor at the UBC School of Population and Public Health, and also a vice president in public health and wellness at the BCCDC, and the deputy provincial health officer. So Reka, again, thank you so much for being here and giving us an update on COVID. Over to you, Reka.
Good morning, everybody. Nice to be here, and I'm going to go to the other end of the spectrum. We were in the therapeutics for severely ill patients, and I'm going to go back to the public health components of what we learned from the public health perspective. Can you see my slides?
Yeah.
Okay, good. Thank you.
Oh, maybe not. I'm seeing video being recorded. Can other people see Reka's slide at this time?
Yes, I can see it. The COVID at 9 months of the pandemic.
Perfect. Thanks very much. I actually took the title seriously of the rounds, and again, I'm also presenting the work of a large group of people. So the question is, where have we been? And in order to think about where we've been, I think it's really important to remember what it is that we're trying to achieve. One of the things about this pandemic, if we compare it to the last one, which was in 2009, is that we had 350 million users of Facebook in 2009. Now we have 2.7 billion users of Facebook. And much of this response, I think, has been shaped by public opinion as much as by public health evidence. So I find it helpful to go back in the cacophony of what is it that we're actually trying to achieve in a pandemic response. And of course, one is to minimize serious illness and overall deaths. And overall deaths means deaths from all causes, and to minimize societal disruption. I am concerned that we're forgetting that a little bit in the course of all this. So I find it helpful to go back to remember what the overall goal is. The question is, where have we been? Well, this is the graph that depicts the numbers that we look at every single day, our new cases, our new hospitalizations and deaths. And you will see that in March and April, we had what we call the first wave, but really was just the arrival of COVID-19. Then we had a very low hospitalization and case rate in the summer. And then as the rest of the world that's in winter, we're experiencing a winter surge. But that winter surge is still substantially lower than the rest of Canada and much of the developed world. These are the numbers we look at every day. I feel like I contribute to some of the things that, as BCCDC, contribute to some of the things that drives the conversation, which is the daily case numbers. And the daily case numbers, unfortunately, is what everybody's learned to look at, but that's not what really matters. What really matters is the daily numbers in critical care and hospital, and of course, deaths. So to get a little bit of a perspective of where we are in BC, we actually looked at the top 15 causes of death in British Columbia during the course of the pandemic until October 31st. And you'll notice that COVID-19 is 14, both in the top 15 causes of death and also the top 15 causes of potential years of life lost. I also highlighted overdose there because what's happened to overdose deaths is also part of the pandemic experience. That's not to say that COVID-19 control is not important. If we don't have to go very far. If we had mortality rates similar to even Quebec, we'd be number 3. COVID-19 would be number 3 in the causes of death, not in the potential years of life lost. What we're looking at in BC is this is again our epidemic curve, and the reason I'm sharing the different colors with you is to have a sense of where is COVID-19 actually being transmitted. And the dark blue part of this graph represents the people who have COVID-19 who are part of a local case or cluster. And this is really important, is that the vast majority of transmission occurs in these social networks of local cases and cluster. We use some of the language of pandemic influenza, but COVID-19 turns out to be really different epidemiologically from pandemic influenza. It's not, it does not appear to be transmitted through widespread community transmission. It's really through known social networks, which if there are many of them, they coalesce. But we're really, again, a lot of the dialogue is about these broad social measures when really COVID-19 is transmitted in social networks. The other thing that's interesting about COVID-19 is it's something called it's dispersed, which means that the vast majority of cases lead to no transmission, and then about 20% of cases account for 80% of transmission. The reason that's important is that especially initially, we tended to learn from small cases, like small clusters or lack of clusters, and we tended to translate what we learned into or generalize it into the population. So, for example, a hairstylist wearing a mask and seeing 169 clients and not transmitting, we thought, okay, well, then you need to wear a mask. That individual may not have transmitted in the first place. The other thing that's interesting is that it really is local cases or clusters. This is just the epidemic curve from various health service delivery areas, and you'll see that Fraser South, so Surrey, it really does continue to dominate transmission in British Columbia, and all of these graphs are available on the CDC website. The other thing about transmission is where is it occurring, and this is a very sort of crude transmission analysis of where people are actually acquiring COVID-19. About 30% of the time right now we don't know. That doesn't mean they don't know, it just relieves the ability to follow up. But we do know that the most common place to get COVID-19 is your home. The other is in certain types of workplaces, generally workplaces where people aren't able to stay home or practice preventive measures. And then unstructured social interaction. So many of the places where we have a lot of the conversation are actually not the cases where transmission is occurring. So for example, this is an analysis of clusters from Vancouver Coastal Health, and one of the most dominant conversation is of course schools, and you'll see that of all the cases in a month-long analysis, 0.5% actually occurred in schools. And in fact, clusters outside of the home accounted for about 22% of transmissions, with no one setting accounting for more than 10%. And that's I think one of the things we've learned is that safety plans actually work. Fairly basic safety measures render COVID-19 from an easily transmissible condition to a hard to or a poorly transmissible virus. The other thing is the other real question that we've learned about since that question that we've been able to answer is who's at risk. And this graph shows you the distribution of the BC population by age, cases by age, hospitalizations by age, ICU admissions by age, and deaths. And what we know is that this disease is really a mild self-limiting condition for children and young adults by and large. Exceptions, of course, occur. And mortality is very, very strongly skewed in the 7th, 8th, and 9th decades of life. The other part of the pandemic experience that I think, in terms of where we've been, is looking at some of the other consequences of the pandemic experience. This is a graph that just shows you how many people died of overdose during the same period as we've been dealing with COVID-19. And the pandemic, as you know, as I mentioned, is not just a virus. It's an experience that we're all having together, and the impacts of the virus, of the control and the public response need to be measured. And we know that overdose deaths were exacerbated during that time and continue to be so. We've also done a large survey of how people are coping, and have found that young adults, this was an adult survey, young adults had a very, very disproportionate impact of the pandemic, indirect impacts such as poorer mental health, increased difficulty accessing services, not working, not being able to make ends meet. We also know that emergencies like this exacerbate social inequities, and so the same survey also shows that a lot of the indirect impacts of COVID are experienced by those in the lowest socioeconomic status more strongly. What's also important, and I think we do have to remember that, is that these are also populations who aren't necessarily able to take the preventive measures because they're not able to stay home, because they're not able to work from home. They work in settings that may be more crowded and less able to take prevention measures. So it is important for us to measure the overall pandemic, not just what's happening with the virus. So a little bit about where we are today. Well, we know a whole lot more about COVID-19 than we did in March. One of the things we know about pandemic psychology is that people form their risk perceptions about the pandemic early on, and it's very difficult to change that. And one of the things that's difficult is, at a population level, is to respond to the pandemic we have rather than the pandemic that we thought we had in March. So it is, I think it's helpful to think back to what we know now that we didn't know in March. So it is a communicable respiratory infection that is largely mild and self-limiting in the young and healthy. But there is risk of severe illness, and of course, when the entire population gets infected, there's going to be severe illness in each age group, but risk of severe illness is very strongly related to age and, to a lesser extent, predisposing medical conditions. The incubation period is 1 to 14 days, but about 5 days, which makes it very different from something like influenza, for which case and contact management is not a particularly effective strategy. For COVID-19, it's a very effective strategy. Transmission is through close, prolonged contact by and large, from about 2 days before onset of symptoms to up to 10 days, but usually in the early symptomatic period. It's really transmitted through social networks. So one of the most important clinical questions to ask is, do you know someone with COVID-19, or is there COVID-19 in your community? It is seasonal, which we didn't know in March whether or not it would have seasonality. We clearly are having a winter surge everywhere. As I mentioned, it's over-dispersed, so that means most cases don't transmit, and then some cases transmit to a larger group of people. And about over 98% of BC's population remains susceptible, which means epidemiologically we're not really in a different place than we were in March. We don't have any level of population immunity. What we can do with what we know is that case identification and testing, and Dr. Romney is going to talk about that, is a really important part of management, as is isolation and contact management, and that is again a feature of this infection. Safety plans and structure settings make a huge difference. And so even, for example, in healthcare settings, we find that the vast majority of healthcare workers who get COVID get it from the community. The second most common place to get it is from unstructured interactions with colleagues, and the least likely to get it is from patients. Some of the challenges, I think, remain stress on the healthcare system. Risk communication, I think we're going to dissect that a million ways when all this is done. And social media, and the degree to which social media drives conversations about where you should do point-of-care tests, where you shouldn't do them, who should be tested, who should get the vaccine. And then where we're going really is the vaccine. You've probably all heard that this morning the Pfizer vaccine was approved by Health Canada, and first shipments are coming next week. The vaccine development really is the same as with any other vaccine, except that the phases of vaccine development were overlapped to make sure that that development is rapid. The two vaccines that are about to be, one of them is approved, which is the Pfizer vaccine, and that is going to be a challenging vaccine to deliver because it has to be stored at -70 degrees. And right now we can't move the vaccine. So it's going to be largely people who can come to the vaccine rather than bring the vaccine to them. Moderna is the next vaccine, which is going to be much easier to manage. It's a -20, so it's a sort of a regular freezer temperature. And the Oxford University vaccine is also showing very promising early results. These are the key populations who are going to be immunized at the beginning. This is the National Advisory Committee on Immunization, so it'll be those at high risk of severe illness, especially those at 70. People who look after them, so people working in long-term care facilities, as well as other essential workers and clinicians who would be needing COVID in their day-to-day work. And then essential service providers, and then people at increased risk. So I think I went through that very quickly, so I think I've left lots of time for Dr. Romney, but I'm happy to take some questions.
This is excellent, Reka. Thank you so much. Again, I encourage people to use either chat box or put up your hands, or I know that many of you have turned off your screen, so I won't be able to see your hands, so please feel free to use the chat box. What I'm going to do is I'm going to go on to have Dr. Romney speak. He's going to speak to some of the, Dr. Romney is a clinical associate professor at the UBC Department of Pathology and Laboratory Medicine and the medical lead of medical microbiology and virology in St. Paul's. And he'll talk to us about the testing strategies and also tracking. I think this will be a very, very important topic. So maybe I'll go to Marc, and maybe Marc, I invite you to present, and then we'll jump right into the question and answer period at that particular time. So I do see the slides. Is that Janet? Is that you? Or
Janet will be advancing them. Yeah, thanks Kendall and Jim and Eric Grafstein who invited me to present. And thank you to Dr. Gustavsson. I've been working with Reka for over 15 years now, and we never envisioned that we'd be working together on a pandemic like the one that we're all experiencing. And so Reka, of course, is on the public health side. I work with you all on the clinical side as Emerge physicians. I'm somewhat in between Emerge and ICU and public health, but I'm going to be focusing on rapid testing today. Testing in general is done for diagnostic purposes, especially the testing that we do here at St. Paul's Hospital, but testing is also a public health intervention, so much like hand hygiene, social distancing, all those other measures, testing and contact tracing, test and trace are probably the most important public intervention for COVID control. All right, next slide, please. So I'm going to focus on rapid testing, which is more for public health purposes and is not really a diagnostic test for patients. And the story goes back to the summer when we started doing evaluations here at St. Paul's on this technology. And the big news for us was back in October when the federal minister for procurement announced that 20 million rapid tests had been purchased for Canada. Next slide. All right, these are the three rapid antigen tests that are currently Health Canada approved. PanBio is an Abbott product, and that's the one that we have received first in BC. There's about 500,000 of them in British Columbia. We're hoping to get the BD Veritor system soon. The bottom antigen test is not available in Canada as yet. It also has some technical issues, so I'm not going to talk about that. Next slide. All right, so a lot of controversy actually about these rapid tests. You know, do they work? Do they not work? People are saying that they're not sensitive enough, but in fact, I think we need to frame the issue another way and talk about PCR testing. PCR testing is very, very sensitive, as you know, overly sensitive. In fact, it's probably very good for diagnosing infections in patients, but beyond that, it's probably too sensitive. It's very slow, as you know. We're always getting requests for rapid, please can you expedite the testing? We do our best to accommodate those requests. We've actually done over 140,000 tests, PCR tests for SARS-CoV-2 at St. Paul since the beginning of March, a massive number. It is not super fast, especially given competing requests for rapid PCR testing from long-term care facilities. We're trying to manage, I think, 15 outbreaks of long-term care facilities in Vancouver Coastal. It's not accessible, especially in more remote parts of the province. There is not accessible PCR testing. It is very expensive as well. So it's highly sensitive. It's probably too sensitive for testing and tracing. So rapid antigen testing has been proposed as part of the solution. And what is very interesting about these little tests, these little cartridges, and you see the PanBio product on the right of the slide, and I have one here in my hand, is that the sensitivity of this particular technology actually correlates very well with the period of transmissibility. And so we want to be able to identify people who are in the transmissible phase of COVID, of their infection, in order to interrupt chains of transmission. So that is the goal of testing and tracing, and the preliminary studies suggested that there was a very good correlation between positivity with these tests and the period of transmissibility. Next slide, please. All right. Not a lot was known about the performance of this technology back in the summer and in the early fall, and so you might have heard about this report in the New England Journal written by Dr. Michael Minna at Harvard, talking about how we should approach rapid testing and testing in general, and that sensitivity is not the be-all and the end-all of testing, and that perhaps rapidity and frequency are more important than sensitivity. Next slide, please. And so he modeled this technology focusing mostly on frequency. So you can see in this slide what's called low analytic sensitivity, and I would call it probably moderate analytic sensitivity, is the rapid antigen test, and the PCR test is at the bottom. And so you can see that this is also a figure showing the viral kinetics of SARS-CoV-2 during a typical infection, and that if you have a lower sensitivity test, but you increase the frequency of testing, you're more likely to capture people who are in the infectious period of COVID, which is the kind of shaded area under the peak there on the diagram. You may miss a small number of people in the pre-infectious period, and you probably will miss people in the post-infectious period. We don't really care about the post-infectious period. We get a lot of false signals using our PCR testing. It drives our colleagues in public health crazy. A lot of people shedding just fragments of RNA that are probably meaningless, and so that is actually a benefit of the rapid tests. Next slide, please. All right, so the big question was, do these actually work beyond the modeling? And this is a slide from a colleague in Rotterdam who was able to evaluate many of these rapid kits back in September, the antigen kits specifically. And Dr. Koopmans was able to state that, yes, these rapid tests, especially the ones produced by Roche SD Biosensor and also the Abbott PanBio test, the one that I just showed you, they perform very well, and they're able to detect CT values, which are a reflection of viral load, up to 26 and probably even up to 30, which again correlates well with the period of transmissibility. Another finding from her study was that not all antigen kits perform equally well. So the highlighted box in the middle of the slide shows some question marks and some green boxes and some white boxes. It shows that there's variability in their ability to detect viral antigen, but the ones that are produced by large manufacturers that are being distributed to Canada and elsewhere are performing very well. Next slide, please. We did our own analysis of this technology at St. Paul's in the Virology lab, looking at two of the leading producers and one local company called Artron. And so again, you can see that SD Biosensor and PanBio performed very well. They were able to reliably pick up infections with CT values of 26 and below. Of course, the CT value is inversely related to viral load. CT is the cycle threshold. It's that moment in the PCR reaction where we start to see positivity. And so both SD Biosensor and PanBio performed very well in our hands. Next slide. Through the fall, others were also rushing to evaluate this technology in places like Barcelona and Berlin and Paris and London, and they all came to the same conclusion that they do correlate actually with the period of transmissibility, but some of the antigen tests don't perform quite as well as others. Next slide, please. All right, the largest study actually came out earlier this month in the middle of November from Public Health England and Oxford University, where they did a massive multi-phase study, much like the studies that are done for vaccine safety and efficacy, looking at the in vitro performance, but also some field studies. They did a large field study where they employed over 10,000 tests in schools and universities, military recruits, and they did find actually that the tests performed as expected, that they were useful and that they could be implemented in those settings. So that is very convincing real-life data that these tests do work to identify individuals in the community who are potentially infectious. Next slide, please. And then more recently, the study came out of the Netherlands and Aruba. Again, another real-life validation. The criticism of these tests recently has been there's no real-life data. I've heard this over and over. There's no real-life data. The sensitivity is poor. Well, that's not true. The sensitivity is moderate. It's appropriate for the purpose, and there are real-life studies actually showing that these tests work when they're used appropriately. Now, in low-prevalent settings, they will not be terribly useful, and that is because the positive predictive value will be low. In higher prevalent settings, like long-term care facilities, they will have tremendous utility, in my opinion, and the data are pouring in to support that statement. Next slide, please. All right, so what are we going to do in BC with these rapid antigen tests? Where are the potential settings? They're not to be used for patients, really, not for inpatients, not for outpatients, unless PCR testing is absolutely unavailable in remote parts of the province, remote parts of the country. We rely on PCR testing for diagnosing COVID in patients. But for public health purposes, we really think that these tests will be useful in vulnerable populations, and the population, of course, that is most vulnerable right now are residents in long-term care and the healthcare workers who provide the care in long-term care. So they will be a priority site, and some of you may know that we already launched the evaluation or a pilot of these tests at Holy Family Hospital long-term care earlier this week. We hope to deploy more tests in more long-term care facilities in Vancouver Coastal and in other parts of the province, hopefully later this month. There's still quite a bit of controversy at different levels of government. We're doing our best to kind of convince people that this is the right thing to do, especially if we have hundreds of thousands of these tests sitting in a warehouse in Langley. Another indication, as I alluded to before, is remote and rural parts of the province. Of course, PCR testing is accessible in the Lower Mainland and in major centers, but we have to be aware that many British Columbians do not live in the Lower Mainland or in major centers, and they do not have great access to PCR testing. And so in those situations, as a preliminary test, these antigen tests could be used, keeping in mind that in areas of low prevalence, again, these tests may not perform terribly well. Another potential use for rapid antigen testing is rapid outbreak identification. And for outbreaks, rapidity is incredibly important, keeping in mind that these are not the most sensitive tests. So if you test 6 individuals in a cluster and they're all negative, that doesn't necessarily rule out an outbreak, but they will have utility in outbreak detection. One other setting that is being considered is correctional facilities. And you all know that there have been outbreaks in correctional facilities. They're considered high risk. Given the environment in correctional facilities, there is a high risk for transmission amongst inmates, and so there is a planned deployment for antigen tests and also something called ID Now. I don't have time to talk about ID Now today. It's another rapid test. It's an isothermal molecular test. It's harder to deploy because there's some technical issues with it, but it'll probably end up being used in BC correctional facilities. These tests can also be used in transient populations. It's another population that is considered to be vulnerable, but doesn't have great access to PCR testing. And so some of you may know that it is being trialed in the downtown east side. It's had variable success, I think, because of the transient nature of the individuals and the rather kind of chaotic environment in which they live. And so trying to capture those people just to do the testing is a bit of a challenge. Now, as we get more experience with rapid antigen testing and more of them become available, we may consider their deployment in workplaces, in universities, and you probably know as well that there is a study right now at YVR looking at their utility in passengers on domestic flights flying with WestJet. Next slide, please. Okay, someone like that. All right, so again, sensitivity is not perfect, but in these kinds of situations, speed trumps perfection. That's what I like to say. Speed trumps perfection. These are rapid antigen tests. They're not called sensitive antigen tests. They are rapid, and rapidity is absolutely critical to identify people who are transmissible. We can't wait 36 hours for a PCR test, or in the States, 7 days for a PCR test in some states. That just is not going to work. That's a failure of the whole testing and tracing program. So rapidity and frequency is also critically important. If you can do the testing more than once a week, probably, depending on the reproductive rate of the virus in your setting, that will be even better. We need to be careful. Not all rapid antigen tests are equal, and these are not definitive tests, so that a positive result would require confirmatory testing by PCR, and so the protocols are being developed in order to ensure that a second swab is collected in order to confirm the initial positive. Protocols are almost ready for use in different parts of the province based on those settings that I identified in a previous slide. Of course, people don't like getting an NP swab. It's actually not painful if it's done correctly. It's a bit uncomfortable, but if it's going to be done 3 times a week, it'd be better to get a nasal swab or possibly a mouth rinse. All the manufacturers are working on this, and I think Abbott, which is the producer of this test kit here, the PanBio kit, has, I think, already delivered an application to Health Canada for nasal swabs, specifically the BD Veritor product, which I hope will be coming to BC soon, is also for nasal swabs. I think that would be much more acceptable to have done 2 or 3 times a week. Next slide. I think that's my last slide. Okay, that's it. Thank you to all. Thanks to all the Emerge docs who've been supporting us, and thanks for working on the front lines. Thanks for being very patient with our testing. It's a rather chaotic environment in the virology lab here at St. Paul's, as I'm sure is the case in other labs in BC. Maybe when this is all over, I can show you the lab. It's been completely transformed into a COVID lab, and there's so much equipment and so many people in there right now, we're kind of tripping over each other, but we are doing our very best to support you all on the front lines and to support public health. So thank you very much for your attention.
Great, thank you very much, Marc. Really appreciate your expertise, and Reka, both of you working very, very hard, and your colleagues to help keep us safe. So we want to thank you also. So we have 3 questions posted already, so I'm going to ask them. If you have any additional questions, please keep posting. And Reka and Marc, if you don't mind, if there are questions we can't answer, I'd love to see if you might want to answer them offline. So first question is there any data on transmission, mortality, stratification by ethnicity, income, or other socioeconomic factors? Reka, what do you think?
So not from British Columbia, because we don't collect those data on a case-by-case basis. There has certainly been data from other parts of the world where, so the United States, where there was a relationship between ethnicity in particular, but I think that was largely dominated by pre-existing conditions such as diabetes and obesity, as well as an inability to isolate. I do think that we do have to keep in mind that we have all these recommendations on how to take preventive measures, and not often focus on the ability to do so, depending on whether or not you can miss a day of work, you're working in the kind of job that can be done remotely, or even necessarily have the ability to understand the measures. So the social determinants of health definitely play a part in your ability to take preventions, but in terms of mortality, we don't have indication. Fortunately, in BC, we don't have that many people who have passed from COVID, which is good, but the dominant feature does seem to be age.
Great, thank you. Next question is, any thoughts on decreasing the quarantine period?
So we've talked about that some, and I think it's a reasonable thing to do. So for example, in other parts of the world, quarantine is 7 days. I think it would need to be done at a national level to make that determination. In practice, I think many of our colleagues focus on the highest risk settings to do the quarantining, as well as quarantine that is mandated by the federal government. And people with low risk exposures tend to be self-monitoring. So we do talk about that. I think it's a reasonable thing to consider, in particular, given that about 97% of people who will get sick by 11 days. We haven't talked a lot about it more recently because we've had some other things to think about, but it's a very reasonable question.
Great. Given mild to no symptoms in kids, how certain are we that schools are not a reservoir or source of outbreaks?
So that's a really good question, and I think that we've looked at the transmission patterns between children and adults, and we just find that when kids get sick, they most likely have gotten it from an adult in their life. The other is that there are outbreak investigations when each case is investigated or at least notified in schools, and about 97% of them don't lead to a secondary case. And then the other really big thing is the ecological evidence that around the world, closure of schools wasn't correlated independently with a reduction in transmission in the community, and opening a school wasn't independently related with increase of transmission in the community. So I think what's important is that it's not a single transmission we're looking for, but the pattern in the community. And we know that, so the other things that we've observed is that, again, if you thoroughly investigate a cluster within the family, very rarely is the child the source of the infection.
Just to add to that, I think kids, especially under the age of 9, are not very good at transmitting this virus, which is strange because for most other respiratory viruses, they are very good transmitters and they tend to amplify transmission. But just as Reka has said, in family settings, usually it's the kids getting it from the parents. And there's very limited actual school transmission, especially when safety plans are well in place, which is the case in BC.
Yeah, I guess speaks to the very good thing that we're tracking data and look at our experience. Can you comment in vaccine safety and side effects?
So do you want to take it, Mark, or shall I?
Go ahead.
Okay. So in early data from Pfizer, the side effects have been the common ones: pain and redness at the injection site, some fatigue, muscle aches, and headaches, and no notable serious side effects in the study population. There is ongoing monitoring. There's going to be a post-marketing surveillance. Vaccines are the most surveyed product that we put out there. There is going to be very careful surveillance for rare side effects because the rare side effects aren't going to show up in a trial of 40 to 50,000 people. So that's something that we are going to monitor. One of the things that I have been a bit worried about is a lot of discussion about this new technology of mRNA vaccines. And although there haven't been mRNA vaccines marketed in the past, and you know, we talk a lot about the speed of the development of mRNA vaccines. In fact, they've been in development for some years. There's a wonderful paper from 2018 in Nature about mRNA technology for vaccines. So I just want to make sure that people know that the technology that's being used to develop the first 2 vaccines has actually been in development for some years and before the pandemic.
Mark, do you want to add to that? Thanks, Reka.
No, I think that's a good answer. There's going to be a lot of post-vaccine deployment surveillance. I think it's already started in the UK, where they've had maybe 2 cases of allergic reactions. This is to be expected. You know, no vaccine is perfect, and of course the adverse events get a huge amount of publicity, but the denominator is never mentioned. All those people who tolerate it so well. So let's keep that in mind when we read media reports of what might have gone wrong in 1 or 2 people, and balance that out with the benefit and also all those people who tolerated the vaccine perfectly well.
Yeah, and I think one of the things is that coincidences get to be reported. I will never forget the story of a pediatrician who told me that that a patient, a child had a seizure in her office as she was drawing up the vaccine, and if that seizure had, so that clearly that she hadn't administered the vaccine, but if that seizure happened 10 minutes later, that family would have believed that the seizure was related to the vaccine. So we do find that a lot of coincidences get reported, and especially in this pandemic where there's just so much in the media.
Yeah, that's a good story about the media highlights and also correlation. So thanks for that reminder of coincidence. The recent Burnaby Hospital outbreak was related to 3 or 4 elderly, extremely vulnerable patients packed in one room, sharing one bathroom. Is this hospital room packing of patients happening at other hospitals? And the flip side is, are we having measures to try to prevent this from happening?
Yeah, that's a good question. It's not unique to Burnaby Hospital. There are hospitals and long-term care facilities all over BC where 4 individuals are sharing a single room. And it dates back to construction designs and practices from the 50s and the 60s and even the 70s. And even St. Paul's here, the new building built in the 80s, there are 4 individuals in a single room. It is far from optimal. And in infection prevention and control, we've been advocating for single patient rooms now for over a decade. And unfortunately, with this pandemic, it has highlighted the inadequacies of for individuals sharing a room, especially if they are elderly and vulnerable and they are in close proximity. And so this is not something that can be managed overnight. And I think that people who are planning for hospital and long-term care design from now on will design hospital rooms very differently. But right now, we are struggling to manage situations, in fact, where, especially in long-term care, vulnerable people are sharing a room and are sometimes unwilling to stay in a corner of the room. They may have cognitive impairment and are moving around the room and even the hallways. We saw this at Holy Family Hospital, where this whole design actually contributed to transmission. And it's something that we're trying to mitigate in hospitals and long-term care facilities, but it's an important issue. It's a difficult issue. It's a very challenging issue for sure.
Thanks, Marc. And Reka, anything to add to that? Great. Okay, we are 2 minutes away. I think rather than squeeze another question in, I think we will maybe Reka and Marc, if you don't mind, there's at least another 6 questions or so. Do you mind if I send that to you offline? Maybe we can get that. And maybe, Jim, we can post it on the Department of Emergency Medicine and BC Emergency Medicine Network websites so people can approach it. And also, Janet, if you don't mind putting the link back up so people can fill in feedback to us for the round. So I'd like to...
Sorry, Kendall. Sorry, Janet, can you capture the chat box?
Yeah.
Yeah, I've been saving it as we go, so I'll pull it up later and format it.
Excellent. I want to go back to Jim to close up the session. Before I do so, really want to thank you, Marc and Reka, for really excellent information. Very, very helpful. And also want to thank Dave Sweet. And of course, I want to thank Eric Grafstein, who is actually the brainchild behind setting this round, getting our speakers here. So thanks, Eric, for that. Jim, hand it back to you.
Oh, thanks very much, Kendall, for hosting and being so gracious. And Dave, Marc, and Reka, thank you so much, and Merry Christmas